Let's talk about brain injury. The most important consideration with any head trauma is whether the brain itself is injured. Even what looks like a minor blow can cause major damage if blood flow is obstructed or tissue perfusion drops. The brain has no way to store oxygen or glucose in any meaningful amount, so cerebral cells depend on a constant blood supply. If that blood supply is interrupted for even a few minutes, irreversible brain damage occurs. Brain injuries can be classified as closed or open. A closed or blunt traumatic brain injury happens when the head accelerates and then decelerates suddenly, like in a fall or a car crash. The skull and dura stay intact, but the brain tissue gets damaged inside. An open or penetrating injury occurs when an object pierces the skull and dura, directly damaging brain tissue, or when blunt trauma is so severe that the scalp, skull, and dura are all disrupted. We also divide brain injuries into focal and diffuse. Focal injuries include contusions and hematomas. Diffuse injuries include concussions and diffuse axonal injury, or DAI. Contusion. A contusion is essentially a bruise on the brain. It happens when the brain strikes the skull during sudden acceleration or blunt trauma. The frontal and temporal lobes are the most common sites, especially near the sylvian fissure and orbital surfaces. The clinical picture depends on the size, location, and surrounding edema. A patient may present with loss of consciousness, stupor, and confusion. The effects of a contusion, especially hemorrhage and swelling, peak around 18 to 36 hours after the injury. Temporal lobe contusions are especially dangerous because they can increase intracranial pressure and lead to herniation. Key takeaway: contusions can worsen over time, so careful monitoring is critical even if the initial exam looks stable. Intracranial hemorrhage. Bleeding into or around the brain is another major type of injury. These are called hematomas and are classified as epidural, above the dura, subdural, below the dura, intracerebral, within brain tissue itself. The danger comes from the expanding blood clot, which increases intracranial pressure and compresses vital tissue. A small, rapidly developing hematoma may be fatal, while a larger, slowly developing one may allow some compensation. Epidural hematoma, EDH. An EDH is usually caused by a skull fracture that lacerates the middle meningeal artery. Bleeding in this space builds quickly, and pressure rises fast. The hallmark pattern is 1. Brief loss of consciousness at impact. 2. A lucid interval. The patient seems awake and conversant. 3. Rapid deterioration as compensation fails. Restlessness, confusion, coma, and then sudden herniation signs like a fixed, dilated pupil or paralysis. Uncal herniation is the most common with EDH, compressing the midbrain. Key point: EDH is a neurosurgical emergency. Treatment requires burr holes or craniotomy to evacuate the clot and control bleeding. Subdural hematoma, SDH. A subdural hematoma forms when veins bridging the dura and brain are torn, often from trauma. Acute SDH develops quickly after an injury, often a fall. Signs include decreased level of consciousness, unequal pupils, and hemiparesis. Without rapid surgery to evacuate the clot, mortality is high because of associated brain damage. Chronic SDH is slower and most common in older adults with brain atrophy. Even minor trauma can cause bleeding that accumulates over weeks to months. Symptoms may look like a stroke, headache, fluctuating neurosigns, personality changes, seizures. The clot eventually breaks down and thickens into a motor oil consistency. Treatment is usually burr holes or craniotomy. Intracerebral hemorrhage. Here, the bleeding is inside the brain tissue itself. Causes include trauma, hypertension, aneurysm rupture, vascular malformations, tumors, bleeding disorders, and anticoagulant therapy. Onset can be insidious, starting with neurologic deficits and headache. Treatment focuses on controlling ICP, fluids, electrolytes, and sometimes surgery if the clot can be accessed. Concussion. A concussion is a temporary loss of neurologic function without structural damage. It's sometimes called a mild TBI. Most concussions come from blunt trauma, direct blows, or blast injuries. Symptoms vary depending on the area of the brain involved. Frontal lobe involvement may cause bizarre or irrational behavior. Temporal lobe involvement may cause amnesia or disorientation. Patients may be discharged once they return to baseline, but need close monitoring for red flags: worsening headache, vomiting, abnormal pupils, seizures, slurred speech, or weakness. These signal a more serious complication. Repeated concussions can lead to chronic traumatic encephalopathy with long-term personality changes, memory impairment, and motor disturbances. Diffuse axonal injury. DI is caused by shearing and rotational forces that stretch and damage axons throughout the brain, the hemispheres, corpus callosum, and brainstem. There may be no visible lesion, but the injury is widespread. It's associated with immediate coma, posturing, and global cerebral edema. Prognosis is poor compared to focal injuries. Medical management. Every head injury is assumed to involve cervical spine injury until proven otherwise, so immobilization is essential. Diagnostics include CT and MRI for structure, PET for function. Treatment is directed at preventing secondary injury, things like edema, hypotension, hypoxia, or electrolyte imbalance. The Brain Trauma Foundation provides guidelines to standardize care and improve outcomes. Surgery may be needed for clot evacuation, fracture repair, or scalp repair. ICP monitoring is common, with CSF drains available if needed. Supportive care includes ventilatory support, seizure prophylaxis, fluid and electrolyte balance, nutrition, and sedation. Propofol is often preferred because it allows quick neurological assessments. When injuries are incompatible with life, brain death must be confirmed. The 3 cardinal signs are coma, absence of brainstem reflexes, and apnea. Families need support in understanding organ donation and end-of-life decisions. Assessment and nursing process. The Glasgow Coma Scale is the cornerstone for assessing level of consciousness. It scores eye-opening, verbal response, and motor response, with 15 being normal and 3 being deep coma. A score of 8 or less typically means severe injury. Assessment includes neurologic checks, vital signs, motor function, reflexes, pupils, and ICP monitoring if in place. Subtle changes are important and must be recognized early. Nursing diagnoses and interventions. Common issues include airway clearance, risk for ineffective tissue perfusion, impaired nutrition, impaired thermoregulation, impaired skin integrity, and difficulty coping. Key interventions include airway management, suctioning, positioning, preventing aspiration, monitoring blood gases. Neurologic monitoring, frequent GCS checks, pupil exams, motor strength, vital signs. ICP management, HOB at 30 degrees, avoid neck flexion, stool softeners to prevent straining, maintain oxygenation, sedatives to reduce agitation. Fluid electrolyte monitoring, sodium shifts, osmolality, urine output. Nutrition, early enteral or parenteral support. Injury prevention, padded rails, minimize restraints, reduce stimuli. Thermoregulation, treat fevers promptly. Skin integrity, frequent turning, skin care, repositioning. CAC coping and psychosocial aspects. TBI often leads to memory loss, distractibility, impulsivity, slowed thinking, and emotional changes. Rehabilitation involves neuropsychology, cognitive retraining, behavior modification, and structured sensory stimulation. Families need support as they face personality changes, unpredictable recovery, and stress on relationships. Support groups and the Brain Injury Association of America can be invaluable. Key complications include decreased cerebral perfusion pressure. CPP should stay above 50 mmHg. Cerebral edema and herniation, especially in the first 48 to 72 hours. Impaired oxygenation and ventilation. Fluid, electrolyte, and nutritional imbalances. Post-traumatic seizures, immediate, early, or late. Prophylaxis is effective for immediate and early seizures, but not late. Home, community, and transitional care education continues throughout hospitalization and after discharge. Families must understand expected limitations, complications, and when to seek medical help. Written instructions help reinforce learning. Rehabilitation starts early and continues for years. Goals are to maximize function, adapt to deficits, and return to the community. Patients may join support groups and benefit from referrals to national resources. Complications to monitor for after discharge include seizures, infections, and bone overgrowth in joints. Ongoing health promotion, screenings, and follow-up are vital. With effective management, patients should maintain airway, oxygenation, and fluid balance, achieve adequate nutrition, avoid injury, infections, and skin breakdown, maintain normothermia, show improvement in coping, orientation, and sleep cycles. Families demonstrate adaptive coping, no post-traumatic seizures or effective seizure management if needed, active participation in rehabilitation and preparation for discharge.